Anorexia nervosa is a psychiatric disorder characterized by little desire to eat. It affects 1 to 3% of U.S. women and is an estimated 1% of pregnant women. As healthcare providers, it is important to understand how this disorder affects women pre- and postnatally in an attempt to improve the outcomes for mother and baby. This research paper aims to summarize the findings of peer-reviewed studies between 2010 and 2020 that met the criteria to answer the question, do pregnant women with anorexia nervosa have more cases of infantile low birth rates than pregnant women without anorexia nervosa? Multiple research studies have been conducted in an attempt to understand if or how anorexia nervosa with a pregnant woman affects a newborn baby. By reviewing 2 studies that explore the relationship between the presence of anorexia in a pregnant mother and adverse fetal outcomes, it is unclear if there is a significant correlation between the two. The studies that were analyzed in this paper concluded that a woman with a history of anorexia nervosa were at a higher risk of giving birth to low birth weight babies when BMI was not taken into account. However, when BMI was defined as a corvality, there appeared to be little correlation between maternal diagnosis of anorexia and cases of infantile low birth weights. Further study is needed to identify other factors that could influence low birth weight in babies of anorexic mother. When a pregnant woman has anorexia nervosa, their newborn infant is at risk for low birth weight and further neonatal complications. There have been many retrospective systematic reviews exploring this topic. However, much of the research has not led to concrete findings. Much of the research that is done in the field is exploratory and lacks enough evidence to form conclusions that might guide further nursing practice. Due to this topic being a very specific area of focus, there is little research that contests the article that are currently published.
In developing our research question, we discussed our fascination with pregnancy and the birthing process. All 4 of us had previously taken obstetrics theory and clinical, like you all, and we all felt that this research could help further our knowledge in the field. While researching the keyword anorexia nervosa, we found articles about anorexia affecting birth outcomes and mortality, which we thought was super interesting. With a lot of discussion and questions, we narrowed down our topic to specifically look at birthing outcomes. Using Pickett as a tool to help guide our search was really beneficial, especially because it was our first time delving so deeply into such a specific research topic. We originally thought that we had to answer all 5 parts of the acronym, but after talking with our professor and doing a lot of research, we realized that the acronym is to be used more as a guideline. From there, we were able to reframe the comparison question, and even though our question did evolve and change over time, with thorough research, we eventually were able to answer all parts of the Pickett question. While acquiring evidence, we used databases such as EBSCO and JSTOR, and after that, we used PubMed for more medical-based research, and we only used peer-reviewed sources from academic databases.
Both of the articles thoroughly explain their studies. The article by Macaulay does not include a review of the literature, but everything that was included in the article was explained well. Therefore, there was no significant gaps in the literature of this article. Eagles also explains their study well, and there are no gaps in the literature review of this article. Eagles and Macaulay both make a very compelling argument about if and how being anorexic or having a history of anorexia nervosa has an effect on the birth weight of neonates. Eagles explains, of the 11 studies identified of pregnancy outcomes in AN, all but 2 concluded that women with past or present AN had babies of lower birth weight. Here, the author is informing his readers that the majority of studies conclude that mothers with a history of anorexia nervosa tend to have babies with lower birth weights. Macaulay explains that the results of their study concluded that women with active or a history of anorexia nervosa give birth to babies with lower birth weights. Macaulay then goes on to say, when BMI pre-pregnancy was included in the model, the effect of maternal history of anorexia nervosa on birth weight disappeared. Macaulay explains that neither of the studies that adjusted for maternal pre-pregnancy BMI found that babies were lighter than those in comparison pregnancies. That is, when the maternal pre-pregnancy BMI is taken into account, the question of whether or not anorexia has an impact on neonatal birth weights disappears. Macaulay further explains that women who suffer from anorexia nervosa typically have poor nutritional status, which leads to low birth weights and preterm births. Both authors make compelling arguments, and it is easy to understand the role that pre-pregnancy BMI plays in the birth weight outcomes. The authors make it clear that women with anorexia nervosa are more susceptible to giving birth to babies with lower birth weights. This disparity is what makes it difficult to analyze the correlation between anorexia nervosa and the incidence of low birth weight babies. Because taking into account this confounding variable drastically changes the results, it is clear that more studies need to be conducted in order to have reliable evidence that could be used to guide nursing practice. Both articles have strengths and weaknesses within them. One of the major strengths is that both articles had large sample populations, which gives a more accurate representation of pregnancy outcomes of anorexic mothers and gives the study more credibility. Another strength is that the exclusion criteria is very specific in order to get the most reliable outcomes that meet the goals of the study. Both articles are considered case control literature reviews, which means that both articles have a lower risk of bias with a higher quality of evidence. In Eagle's article, all case record diagnoses were taken from psychiatric medical record departments in Grampian, Northeast Scotland, which presents the opportunity to include all women with a history of anorexia from 1965 to 2007. Another strength is that it is specific to pregnancy outcomes of women with history of anorexia nervosa, is that the comprehensive data was taken from the Aberdeen Maternal and Neonatal Data Bank, which permits accurate comparison of anorexic women with non-anorexic women for maternal age, year of first delivery, and parity. This also allowed for statistical adjustments for important confounding variables such as smoking status, maternal BMI, and social class. Macaulay's article also has significant strengths. Macaulay states, the strength of this study include the use of data from large longitudinal prospective community cohort. They were able to use a comparison group that had other eating disorders rather than just the general population so that they could see how pregnancy outcomes truly differ in women with anorexia nervosa. Although both articles have significant strengths, they each also have weaknesses. One major weakness in the articles is that different results were obtained depending on whether or not pre-pregnancy maternal BMI was included in the study. Macaulay explicitly explains, the main weakness of this study is that women were classified according to self-report of lifetime anorexia nervosa or bulimia nervosa or both. Another weakness that this study had was the use of self-reported questionnaires in identifying those with anorexia/bulimia. Self-reported data always comes with the risk of inaccuracy and skewed results. Based on the articles analyzed in the literature review, no conclusion could be made to answer the posed research question due to the need for more research into this specific topic. This study brings awareness to the lack of information about this population group and encourages further research into this field. Macaulay's study met a majority of the criteria related to evidence appraisal. Despite this, the article does not meet evidence-based practice criteria and is a reliable source of information. The second article by Eagles also met the majority of the criteria related to evidence appraisal. This study, on the other hand, looked at records of patients that had an official diagnosis of anorexia from a provider and were admitted in the hospital. Both of the studies, though not perfect, are sound enough to be regarded as reliable resources to include in a future study in this field to draw reference off of. The team members of this study agreed with this conclusion and were satisfied with the article studies that were conducted.
Despite the progress that is being made in putting a higher emphasis on evidence-based practice, bringing these practices into a clinical care setting can still be difficult. While there are 7 steps to evidence-based practice, the implementation step is the most challenging. This is due to the fact that bringing newfound information into a healthcare institution involves many complicated variables. It may be difficult to ask nurses and doctors to step away from their jobs to engage in training, or to call them in on a day off. In areas where there is a shortage of nurses, this would be especially difficult and could even be considered an ethical dilemma. In addition to this, hospitals and clinics are always moving and changing, and adding another piece of the puzzle might be met with resistance. To combat the barriers that may be met when implementing new evidence-based practices, it would be important to present the information in phases and slowly introduce it into the environment. An article detailing the results from the Expert Recommendations for Implementing Change Project, the ERIC project, published by Brian J. Powell of University of Pennsylvania, compiled a list of implementation strategies for clinical practice. Of this 73-point list, one strategy stood out to us as a plausible option for disseminating the information from our research and changing nursing practice. Conducting educational meetings with healthcare professionals in the community, at clinics, and in hospitals would be one way to distribute the information in the informative research. Holding meetings for all members of the healthcare team to teach them about the current research surrounding anorexia as it relates to pregnancy outcomes would be very beneficial, as it would help providers better serve their clients. The first point to present would be the prevalence of anorexia nervosa amongst pregnant women. It would be important for nurses to know that about 1% of their pregnant patients suffer from anorexia. Next, it would be crucial for nurses to be aware and to be able to recognize the signs and symptoms to look out for. Nurses should be concerned if their patients have not gained weight in 2 consecutive meetings, if they have a history of an eating disorder or obsessive-compulsive personality traits, if they have low body fat or tooth decay. Physiological symptoms may exist as well. Nurses would be taught to recognize the risk factors, including being a young female, being genetically disposed, participating in professional sports, and media and societal expectations. Once providers have the information needed to identify anorexia nervosa in pregnant patients, they can provide them with the support and the resources they need to have a healthy pregnancy and a healthy baby. In order to complete the task of educating healthcare workers, there needs to be a group of individuals who are experts on the topic of anorexia nervosa and pregnancy. These individuals would be the educators who hold the meetings for healthcare providers. State or regional representatives could coordinate with hospitals and clinics to organize classes that would be mandatory for providers, especially those working in OBGYN and maternity units. For this change to be sustainable, agencies would need to set a standard for how often their employees would have to get recertified by retaking the class. As new research and new knowledge develops on this topic, it would be important for nurses' knowledge to develop as well. With a team of passionate educators who stress the importance of recognizing, educating, and supporting pregnant mothers with anorexia, healthcare workers could incorporate this knowledge into their everyday practice. To determine the effectiveness of these education classes that would be provided, it would be important to evaluate how many people are utilizing this new information. To evaluate how many people are utilizing the information, we could encourage organizations to ask their employees to report how often this research has helped them to provide better care to patients. We could also ask unit managers to report when and how often they see referrals being made to psychiatry to help mothers deal with their anorexia. Additionally, hospitals could report if they witness mothers with anorexia having better birth outcomes, especially as it pertains to the birth weight of their baby. With the data that we gather when evaluating the effectiveness of our strategies, we could improve upon our methods of delivery with the new information. It would be important to recognize the flaws in the system, especially because it would be the first time organizations are taking this class, and the feedback we get from our nurses and providers, we could implement a system that works for them and in turn serves our communities better.
Educating nurses and other healthcare providers about anorexia and the potential pregnancy outcomes for these patients is very important and would be a beneficial change to current practicing guidelines. It is crucial that nurses, specifically those who work with pregnant women, know how to treat and educate patients with eating disorders like anorexia nervosa. It is important that providers are able to identify anorexia nervosa in pregnant patients so that they are able to provide the information and support that is needed. Changes in educating healthcare professionals about pregnant women with eating disorders can be done in the community, in clinics, and in hospitals by way of educational sessions. At these sessions, specialists are to inform those who work in healthcare of research surrounding anorexia nervosa and what to look out for in pregnancy.